Thank you, sir.
Thank you very much. Just let me share my presentation with you. I'm trying to find it. Check it. I'm unable to share it. No.
Yes, sir. We saw your screen for a moment.
No, it's another one. Let me, because I just had the. Yes, I just got it. So you can see the. Is it clear now?
Yes, yes, sir. Please proceed.
Okay. So thank you very much for the introduction. Today I will be talking about some updates in the non-transfusion dependent thalassemia. And these are all out of the new guidelines that we have just a few months ago worked on and published together with the Thalassemia International Federation, which you can download on their site. This is my disclosure. So let me first start with some molecular understanding and genotype-phenotype association. I'm not sure about the group, but I'm sure we'll be having a diverse group from young physicians, students, to well-established hematologists. So excuse me if some of the material is a little bit simple. So the whole story starts, as you know, in the beta thalassemia with an imbalance between the alpha to beta globin chain. This imbalance would lead to what we call red blood cell pathology, and this is because of reduced or absent synthesis of the adult hemoglobin. So there will be accumulation of the excess alpha on the red blood cell. This would lead to what we call ineffective erythropoiesis within the bone marrow and hemolysis out of the bone marrow. These both ineffective erythropoiesis and hemolysis would lead to what we call chronic anemia. Now there is some modifiers like a milder beta mutation, a co-inheritance of alpha, an increase in gamma, that would lead to a minor form of severity of the disease. So the whole pathophysiology is related to the imbalance, the ineffective erythropoiesis, hemolysis leading to anemia. And as a result of anemia, one would get increased absorption, so iron overload. And if transfused, the patient will get excess iron overload. Previously, we used to divide the patients and we used to talk about mostly genotype, phenotype, like beta, beta 0, beta plus, beta plus, beta plus, beta 0, and relate them to the phenotype like carrier, intermediate, and major. Until recently, like 10 years ago, when we started to use the transfusion requirement as a key driver to the pathophysiology and allowed us to standardize easier this disease and divide it into non-transfusion dependent and transfusion dependent. So NTDT versus TDT. NTDT, which is our talk today, are those patients who do not require continuous blood transfusion for survival. However, they might require every now and then blood transfusion for occasionally surgery, pregnancy, infection, intermittently, specifically for growth, school performance, or specific morbidities. And sometimes with age, we're noticing that these patients are requiring more and more blood transfusion. While the TDT cannot survive at all without blood transfusion, and this is what we used to call beta thalassemia major. And in this slide, I try to summarize all genotype, phenotype, clinical presentation, transfusion requirement, as well as the division into TDT and NTDT. This is from an interesting review that we have a few years ago finalized and published in the New England Journal of Medicine. So the pathophysiology is really easy if we look at it from the imbalance, ineffective erythropoiesis hemolysis, and leading to anemia. And let me now concentrate specifically in the absence of transfusion, which is the NTDT. So once again, the ineffective erythropoiesis would lead to a lot of complications related to anemia, and also the hemolysis will lead to what we call hypercoagulability. This will all lead to primary iron overload. So the complications in this group of patients are dependent on all these factors: the ineffective erythropoiesis, hemolysis, and iron overload. Our work started some time ago in 2006, 2005, when I tried together with Professor Cappellini to look into our patients with TDT and NTDT and try to see some of the morbidities or complications we have in NTDT that are not present in TDT, such as right heart failure, pulmonary hypertension, extramedullary hematopoiesis, venous thrombosis, venous ulcers. And that was in one of the research that we have done on around 30 or 40 patients in Milan and the same in Lebanon. But then we thought that we need a further stronger data on a large number of patients, where the optimal care study was done that was published in Blood 2010, probably among the most read articles on thalassemia intermedia or NTDT, where we looked into around 584 patients with beta thalassemia intermedia from several countries and tried to look, and this is a cross-sectional study, are these complications only case reports, or yes, truly, these patients have such a morbidities that are different. And when I talk about NTDT in this data, I'm talking about those that are never transfused. And when I talk about TDT, I always talk about TDT with a pre-hemoglobin level of 9 or 10 and very well transfused and chelated. So we cannot compare a TDT that is not well transfused because it will act like an NTDT. Once again, the complications are the same: thrombosis, pulmonary hypertension, extramedullary hematopoiesis, and these complications increase with age in this group of patients. And most of the complications started after the age of 10. So let me now divide these complications dependent on the pathogenesis of it. So let me look into ineffective erythropoiesis that leads to anemia. This would lead to this anemia that will increase the morbidity, decrease the quality of life, increase mortality, and increase the economic burden on the government or third-party payer. And in this study that we have done some time ago, showing that the more GDF-15, the higher, which is more ineffective erythropoiesis, more severe the morbidities are. But we have clearly shown that those patients, the higher the hemoglobin, the less morbidities they have. And if you look at the green versus the red color, you would see that for those with a hemoglobin more than 10, they have by far less morbidities and better survival than those with the hemoglobin less than 10. Not only a single morbidity, but multiple morbidities. And if you increase the hemoglobin by 1 gram per deciliter in this group of patients, and this is from a study on around 150 patients that was published in Annals in Hematology, you would see that by increasing this hemoglobin to above 10, the morbidities will decrease in this group of patients. So I have shown you clearly that if you increase the hemoglobin in an NTDT, this will decrease the morbidities, decrease the mortalities in this group of patients. I'm trying to walk you through a story where I will end by the novel therapies and the new clinical trials where they have used these numbers to move on in the trials. What about primary iron overload? Why should these patients have iron overload if they are not transfused, because the ineffective erythropoiesis will lead to a reduction in hepcidin and increase in absorption of iron. So these patients will have severe iron in their liver, maybe not at the same rate like a TDT, but ultimately they will have severe iron in the liver. And not only in the liver, the iron will be, because this iron is associated with each and every morbidity in this group of patients. So getting hepatic fibrosis, cirrhosis, hepatocellular carcinoma, associated with silent brain infarct, associated with pulmonary hypertension, with endocrinopathy, and recently with a lot of proteinuria and renal dysfunction in this group of patients. So therefore, it's very important for us to look into the measurements of these patients. What should we use in order to see if these patients are severely iron overloaded or not? The best would be, as one would think, is a serum ferritin. However, from the first part of the slide on the left, you would see that serum ferritin in an NTDT or in a thalassemia intermedia underestimates the amount of iron. So for the same liver iron concentration, the serum ferritin is always lower in an NTDT. This means that we need to start to chelate our patients at a lower serum ferritin compared to those with a TDT. So the slide in the middle, or the curve in the middle, shows you that if the serum ferritin is less than 300, no morbidities, minimal. If it is above 800, multiple morbidities. And serum ferritin of above 800 is similar to a liver iron concentration of above 5. This is really very important, specifically in areas where MRI is not all the time available, so that you would use the serum ferritin to chelate this group of patients. So above the age of 10, with a serum ferritin above 800 or an LIC above 5, these patients should be chelated. And this shows you that the anemia severity is associated also with the increase in ferritin. So the more anemic the patient is, the more the serum ferritin is high. And this is a very nice, from a new publication also that we have done, showing you in this Kaplan-Meier that on the left, again, the green and the red. So if the hemoglobin is above 10, survival is better. If serum ferritin is less than 800, survival is better. If you combine both components, meaning if the hemoglobin is less than 10 and the serum ferritin is above 800, you will get by far worse survival in this group of patients. So I have shown you in these two components of the presentation, a hemoglobin of 10 is really very important to reduce morbidities. A serum ferritin of less than 800 and better, and even less than 300 or around 300 also is associated with less morbidities in this group of patients. The third component would be the hemolysis, which would lead to hypercoagulability. We have multiple reasons why these patients are hypercoagulable. Splenectomized, a good number of them, endothelial injury, an increase in platelets count, abnormal endothelium, circulating microparticle. But the most important is that these patients have pathologic red blood cells. And there will be a flip-flop mechanism, and phosphatidylserine will occur on the red blood cell membrane. This will act, the red blood cell per se, would act like thrombin generation, leading to thrombosis in this group of patients. From an old study that we have done on around 8,860, also once again showing that these patients are more thrombogenic than the TDT or thalassemia major patients. Specifically, this is important for us as adult hematologists, where we are consulted regularly on these patients prior to a procedure, splenectomy, during pregnancy, if they can receive oral contraceptives, if they have recurrent miscarriages, if there is a severe illness and the patients are prolonged immobility. So these patients are 4 times more at a risk of clotting than the TDT patients. Also, these patients have more brain infarcts, silent brain infarcts. Whether these are of significant or not, still we need to have further studies. These studies were done in Iran, Lebanon, and USA. Because of this, we tried to calculate and have a formula through which we could see who are the patients that are at a risk, and should we prophylactically anticoagulate them during surgery or during a certain procedure. This was published in the American Journal of Hematology, and this is a very interesting chapter for you who are interested in thrombosis to look at in the TIF new guideline. This would lead, as you know, to pulmonary hypertension. Those that are splenectomized with a lower hemoglobin, higher iron overload, are at a higher risk of pulmonary hypertension. This is seen in a very big study, the Webthal group from the Italian, that have shown that with age, splenectomized, these patients are higher risk of pulmonary hypertension. Pulmonary hypertension will remain for a certain time, even 8 years after diagnosis, and this would lead to significant morbidity and ultimately mortality in the group of patients. In the guidelines, the new guidelines, will see several algorithms that are interested, so that you should look at them. And for sure, all the management of this group of patients should be in a multidisciplinary team. So the presence of a cardiologist is really of utmost importance in looking at pulmonary hypertension in this group of patients. This is from a recent publication, How I Treat, that I have published in Blood recently. And it shows you all the morbidities that you find in an NTDT. And this is one of the algorithm in a simplified way for you to look at and discuss with your cardiologist for your patients who have pulmonary hypertension. Splenectomy, that was once used as a very treatment, a very important treatment for our patients, is now obsolete and not used anymore. Because as you know, that all the complications that we see in an NTDT are associated with splenectomy. Not only thrombosis, not only infection, but each and every complication. So if you look into the data, for example, 20 years ago, the majority of NTDT or thalassemia intermedia were splenectomized. If you look at the data now, 90% are not splenectomized. So the morbidities in an NTDT is an interaction between three components. The orange is the ineffective anemia and hemolysis. The red is the iron overload, and the blue is splenectomy and hypercoagulability. So all of these components would lead to all the morbidities that we see in the non-transfusion dependent patients. So how to manage these patients? This is from the New England Article of Medicine. Until recently, we did not have any modality of managing these patients. The only modality that was available is to monitor iron overload and chelate these patients, and to monitor hemoglobin and transfuse them whenever needed, which was underestimated and never done properly. I remember seeing abnormal fascias, abnormal bone problems, huge spleen in all of these patients. They were not transfused because thinking that, why should we transfuse an NTDT? Although data have shown clearly that when you transfuse them or when you increase their hemoglobin, this is protective against multiple morbidities in this group of patients. So regular transfusion or even irregular transfusion in this group, starting after the age of 10, would improve the survival of this group of patients. Now, to increase hemoglobin, we have several modalities. Some of them are still very small trials. Some of them were not really further investigated. A good example would be hydroxyurea. We have different data from different parts of the world, but yet we do not have a large multi-center trial on hydroxyurea. However, it's worth trying it on each and every patient with NTDT, at least to see what is the outcome in this group of patients. The guidelines of iron overload is clear. LIC above 5 or above 800, these patients should be chelated. When the LIC is 3 or when the seroferritin is 300, withhold and keep on monitoring. If you do not have an MRI, depend on the serum ferritin, but lower the threshold. Deferazirax was the drug that was approved by the FDA and EMEA for the chelation of this group of patients. This is the Thalassemia trial that we published in 2012, where it was a multi-center randomized double-blind placebo, where the primary outcome showed significant reduction in LIC, reaching a dose of 20 milligram per kilogram per day. And this was followed up in year 1 and 2. Safety was there, and we followed up in another trial, the patients till year 5, which is called the THETIS trial, showing also that there is marked reduction and safety, even at 30 milligram per kilogram per day. So reduction in liver improved iron, improved the mortality in this group of patients. So I showed you previously, improving the hemoglobin and reducing the iron, improve the morbidity and decrease the mortality in this group of patients. This is from the How I Treat article that was written. I advise those of you that are interested in NTDT to look into this manuscript. It's really interesting. If you don't have it, you can email me and I can send it to you. So now we know by now that there is ineffective erythropoiesis hemolysis leading to anemia and hypercoagulability, the anemia of varying severity, increased absorption of iron, transfusion every now and then leading to iron overload, and the morbidities are related to these. We fully know that the complication starts after the age of 10, and that we need to chelate the patient at a serum ferritin of above 800 or an LIC above 5. We know that if we increase the hemoglobin, the outcome would be much better. But we don't have except transfusion if needed and chelation therapy. So what are the novel therapies for NTDT? If you look at this triangle, it is similar to what I have started the presentation with, showing you that the blue part, if you want to work on gene therapy, which is not the topic of today, but the alpha to beta imbalance can be corrected by the gene therapy. The green part is related to iron. So instead of chelation, you could modulate absorption of iron. Actually, till now, these studies are still in trial, the minihepsidin studies, and the ferroportin did not move forward well. But the red component is what we're working on now, where you target ineffective erythropoiesis. The most important is luspatercept that have received the FDA and EMEA approval a few years ago, and the pyruvate kinase that will be presented for those of you who are going to the EHA. I will be presenting the data for the first time with an excellent results in a plenary session during the EHA in Madrid. So I will not talk about it because this is still in embargo. I will be talking more about the luspatercept data. What is luspatercept? By now, I think you've heard this a lot. It's the first in-class erythroid maturating agent that will work and enhance late erythropoiesis. It's an intensive development program where it included the BELIEVE or the group with TDT. It included the BEYOND or a group with NTDT that we're talking about today in a phase 2 trial, 145 patient hemoglobin less than 10 above the age of 18. Also, there is a new study on pediatrics, and there is a study on myelofibrosis using luspatercept. This is the luspatercept, what's published in Lancet Hematology, the BEYOND trial that I will describe for you, through which the EMEA approved it as the treatment for this group of patients. After screening, randomized, double-blind, luspatercept 1 milligram per kilogram, around 100 patients, around 50 in the placebo, minimum 48 weeks, then cross over, and the patients will enter the long-term follow-up. The primary endpoint was increase in hemoglobin above 1 gram per deciliter, and the secondary outcome was improved quality of life in this group of patients, or the patient-reported outcome, tiredness and weakness domain score. Demographic were similar. The primary outcome was met. Around 77% of the patients on the luspatercept versus 0 on the placebo improved their hemoglobin by 1 gram per deciliter. The primary endpoint was actually positive in all subgroups, male, females, low hemoglobin, less than 8.5, above 8.5, all met the primary outcome. Around 50% of the patients increased their hemoglobin to above 1.5 gram per deciliter. So which is better than the 1 gram per deciliter. Actually, more patients treated with luspatercept achieved a hemoglobin more than 10 than those receiving the placebo, if you look at those that achieved more than 10. When analyzed by baseline of hemoglobin level, more patients treated with luspatercept also achieved more than 10. And when we looked at further data, this is the updated data, you could see that was presented last year at ASH, that there was a continuous increase or sustainability of the increase in hemoglobin in this group of patients. I will talk, yes. Those patients that improved their hemoglobin had a better patient-reported outcome, specifically for tiredness and weakness. So the secondary outcome was better in those patients who improved their hemoglobin. The safety was there. We thought that these patients might have more thrombosis, no thrombotic events occurred, and no malignancy occurred. And these are 2 points that we looked at carefully. On this slide, I tried to summarize mechanism of action, the population 145 patients, randomized double blind, the intervention 2 to 1, 1 milligram per kilogram increased to 1.25, and the 77% increase in 1 gram, 50% more than 1.5, and this summarizes all the beyond trial. And this is why it was approved by the European EMEA in 2023, last year, and we have integrated this in the new guidelines, which I would ask you if you're interested to look at and read it. So this is how we integrated it in the guidelines. Is there something new other than luspatercept? Yes, the mitapivat, which I told you we will be presenting the anti-DT data at the EHA. I'm sure you know that it's a pyruvate kinase activator, and it was approved for pyruvate kinase deficiency. However, it improves the ATP of the red blood cells, and it has shown very good results in both TDT and anti-DT. The anti-DT data is out. We will be showing it at EHA, and hopefully the TDT data will be out, and we will be showing it at ASH. Also, it went through an extensive program, and we had the phase 2 anti-DT data that was published in Lancet some time ago, and now we will be having the phase 3 Energize trial, which will be presented in few weeks. The Energize T is the major, or the TDT, that we will be presenting at a later stage. So what I did through this presentation is to move you from, or walk you through, the pathophysiology, the components in the pathophysiology, that at the end of the presentation, I have shown you how they act or interact to form and to give us all these novel therapies. Thank you.
Thank you, Dr. Taher, for the extensive yet very simple facts with recent updates on the topic and sharing your extensive work in the field. So now I would request delegates to share questions in the chat box or unmute yourself, and please ask your queries with the expert. Thank you. if not, like I will start with my question. Like, sir, as you mentioned, NTDT, they have a hypercoagulable state. So, especially when they enter pregnancy, like, do we anticoagulate everyone?
I can't hear you well.
So, actually, in NTDT, when they enter pregnancy, do we anticoagulate right from the beginning?
No, I mean, if it's the first pregnancy or if there is no history of thrombosis or no strong family history or no other risk factors, we will not anticoagulate for sure. But prophylactic anticoagulation will be if there is recurrent miscarriage, if there is positive family history, if there is previous personal history of the patient. This is when we will think of anticoagulation. But I mean, we just don't anticoagulate as such.
Okay. So they said there are a few questions in the chat box. I would ask one by one. Like, would you routinely add aspirin in TDT?
I mean, there is no study on aspirin, not a single simple, although it's a simple. However, in my patients, especially the adults that are splenectomized, all of them on aspirin. And even in the pediatrics, I'm starting to ask my colleagues to start these patients on aspirin. What I do usually is after the age of 18, where I see the patient, all of my patients are on aspirin, splenectomized or not, because some small studies previously had shown that it might be protected. But we don't have, to tell you the truth, any evidence-based medicine related to aspirin in this group.
Right. The next question is like, what percentage of NTDT eventually become transfusion dependent, like for various indications?
It's a very difficult question. I cannot know how, but in my cohort, 30% of them became transfusion dependent. With age, if we don't interfere, almost all of them would become transfusion. Because ultimately, if you don't increase the hemoglobin and if you don't chelate them and if you have splenectomized them at a certain time, they will get most of the morbidities. And that the majority of the morbidities needs transfusion, like pulmonary hypertension, recurrent ulcers, thrombosis, all of them. So a large number will be. I forgot to put one of the publications that we have done recently. We looked at a cohort and see actually around 30% will become transfusion dependent. And this is what you call neo-anti-DT, so neo-TDT. So they are new to the TDT.
Okay, actually, the other challenge is like the regular follow-up in NTDT. Thalassemia major, they come regularly, but do you feel that NTDTs, they don't turn up regularly for follow-up?
They don't attend regularly for us, but I'm lucky that most of my patients will come because they are part of the clinical trials. So they always come to be part of the trial. And I have used a lot of patient advocacy. So I always put the younger with the elder and have an advocate that will show them how much complications he got compared, so that they could understand better that they need to be followed up, that there is new things happening, that the concept of transfusion now is there, that we do not accept to see any abnormal facies now in them, that we do not accept that they will go to school without cognitively being better, that they need to grow, they need to get tall, they need to be transfused. So the concept is different than before. So I think if we talk to them about these and if we show them the difference, we will be able to capture most of them.
So, like, again, what would be the indication for stem cell transplant in NTDT? Like, if they have a sibling match and they turn into adolescent?
I think this is too philosophical and ethical. I think it needs, because up till now, we do, I mean, the bone marrow transplantation is being done for the TDT and sickle cell currently. For anti-DT, it is not done unless, I mean, this would be in a trial or out of or with discussion, unless the patient has severe anemia, which he will be then like a TDT patient.
So you want them to transplant like that? Can we take like that?
No, I wanted to discuss with the patient and the family and the ethical part and then decide, because treating the anti-DT patient should be personalized. It's not like TDT, hemoglobin above 10, blah, 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 blah. You follow up a lot. In NTDT, we need to personalize, look at the patient characteristic. I mean, the whole thing is not simple. It's not like 1 + 1, 2 in NTDT.
Like in your cohort, like how frequently you end up doing splenectomy, and like, what would you consider?
In the young, none at all. But in the elderly, the ones previously in the 70s and a good around 60% of them were splenectomized.
Like,
But
what
now,
would be
none.
now none?
None.
Okay. So like there's a one question, like, can a child with 2 years of age not having high HbF level, but a baseline HB was 6, genetics not done, labeled as NTDT and given hydroxyurea trial. So do you give hydroxyurea trial rather than a regular transfusion if the HB is around 6 in a child of 2 years age?
If the child is, I'm not a pediatrician, but if the child is not growing well, I think blood transfusion is the most important. And you don't need to keep on transfusing all life. Now, if he requires at the age of 2, I mean, he might be a TDT. I mean, the term TDT and NTDT doesn't mean anything. I mean, think if your child needs transfusion, transfuse him. Regardless, if he's an NTDT, I mean, I will not punish him and not transfuse him and get all the complications. So let us think about them. If he needs, let's transfuse. If not, no. So if he's not growing well, starting to get abnormal features, having a larger, I mean, we'll transfuse for sure. Maybe maintain on hydroxyurea later after the patient grow well.
So the next question would be like the NTDT presents to us with a large spleen. Then we put them on regular transfusion for growth and hypersplenism, but still we are not able to maintain the hemoglobin target of say 9.5 to 10. So do we have any other treatment agents to add along with this regular transfusion?
This is NTDT or NTDT? I don't know.
NTDT presenting with hypersplenism, large spleen, and growth.
NTDT.
NT non-transfusion dependent.
If they are adults, we could use luspatercept. I mean, it's the only available now. Soon we'll be talking about the metapivir. Hydroxyurea is another one could try. But I don't think there is, we don't have a large menu for these patients.
Like, what would be the dose of aspirin you use in
maybe aspirin, 75 to 100 milligram.
Fine. Fine. So I think, have you tried thalidomide? Like, we have some papers on thalidomide.
Yeah, I've seen, I mean, to me, I need to get the ethical committee approval, and so it's really very difficult. What I know now, I have seen some of the good results. I think one of the companies is trying to do a randomized trial now. So I will be waiting for, if somebody wants to receive it, I'm sure the patient should sign the consent, know all the side effects. But there are some positive results, mainly from India and very few from Italy. And I've had it in the table that I have shown you.
Fine, so thank you. I think we have answered almost all questions in the chat box.
Okay.
If no further questions, I think we can close the session. At the end of the session, I would again thank you, sir, for answering all the questions from our side. And again, thank you for joining with us.
Thank you very much for asking me. Thank you.
Thanks.
Bye-bye. Bye.
We'll close the session. Thanks.